Hello, I'm Dr. Michael Cooney with another video about healthcare directives. In my last talk, we spoke about the advanced directives that every adult should have, namely the living will and the healthcare power of attorney. If you haven't seen that one or you want to revisit it, the link will be in the description below on YouTube. Well, I started to write this talk about another type of directive, State-Authorized Portable Orders. But it became clear that we can't really talk about more than one directive without referring to all of them. So this has turned into a general overview about all types of healthcare directives, including when you might need to have them, when they apply, and how they are used. We'll try to cover this in under 15 minutes, so let's get right into some graphics. Healthcare directives of any kind serve you at a time when you may be unable to speak for yourself, but you know ahead of time how you want to be treated, or more often, how you don't want to be treated. Obviously, the only way to communicate when you are unable to speak for yourself would be to set down your wishes about your care in writing, or to ensure that someone with the legal right to speak on your behalf knows what you want or don't want. Well, that sounds like the advanced directives that we went over in the last video. In fact, that's exactly what your living will or your healthcare power of attorney documents can do for you. Those are great ways of making your intentions known. But in our health system, nothing is done without a doctor's order. So your living will may state that you don't want CPR if you are in the late stages of a disease. You may think that puts you in a do not resuscitate or DNR status, but it's not that automatic. If you are brought to the hospital, a physician needs to determine, first of all, that you're unable to make your own decisions, and then that you are actually at the end stage of a medical condition or that you're permanently unconscious. Then, if you meet the criteria of the living will, the physician can order the DNR status. Only then are you in the status you intended. What if you come in by ambulance? The EMS crew does not and should not pay any attention to a living will. That's for a physician to review. For the ambulance crew, unless they have an existing order at the time they were called, they will treat you in a full resuscitation mode. Even if your healthcare proxy is at your side saying no heroics, the ambulance crew is legally bound to provide advanced life support efforts unless they have a physician's order to limit those efforts. Well, it sounds like we may need orders that don't just exist after an evaluation in the hospital, but orders that you can have at home with you if you need. In other words, portable orders. There are two kinds of these: the state-authorized portable orders and the out-of-hospital DNR order. Let's take a look at the state-authorized portable order we use in my state. That would be the Pennsylvania Order for Life-Sustaining Treatment, or POLST for short. This is a very simple document that can be used to limit aggressive treatments that are not wanted at a certain point in life. Now, this is not something for the young and healthy to complete. This would be prompted by advancing disease states. And unlike the advanced directive documents, this isn't something you can fill out in your living room. It's a document that your physician fills out as part of a conversation with you about your medical status and your goals of care. The top section gets right to the DNR status, that is, what is to be done if you were in cardiopulmonary arrest. Block B addresses any limitations of care short of CPR. Importantly, this includes consideration of mechanical ventilation for situations other than cardiac arrest, for example, respiratory failure from pneumonia. The next section deals specifically with antibiotics. Since infections are often the final terminal event in late-stage disease, Block C allows a choice about antibiotic therapy, which is often considered futile under the circumstances. Likewise, many people fear being kept alive artificially by tube feedings. Block D considers artificial nutrition and hydration given through a tube. The pulse is signed by the physician and by a patient or a surrogate for the patient. Once signed by the physician, it is considered a medical order. There is one other type of directive document that constitutes a medical order. This is the out-of-hospital DNR order, and it's even more simplified than the pulsed order. It is used when the only order needed is a DNR order. Generally, this is signed by a physician for a patient who is at the end stage of a disease and is already in a DNR status in a facility, but who has to travel outside the facility. An example would be the transport of a terminal patient from the hospital to home or from the hospital to a freestanding hospice house. A patient at that stage of things is likely to die in the near term and is appropriately in a DNR status in the hospital. He doesn't want heroics attempted just because his heart happens to stop in the back of an ambulance. The out-of-hospital DNR order leaves no doubt about his wishes regarding resuscitation. This type of portable DNR order is signed by the physician as a paper document, but there are also bracelets and necklaces with the DNR order on them that can be worn at all times. So now we've discussed 3 different types of directives, from ones that indicate intent all the way to actual physician orders. If you're wondering why we need all these different documents, trust me, they all have a place and a purpose. The ultimate purpose is to ensure that your wishes are met. But when you would have these different documents and how they are used depends on where you are in life and what your state of health is. Remember that the healthcare system is set up to do aggressive, heroic resuscitation and life prolongation as the default, whether it's appropriate or not. Healthcare directives came into use specifically to allow people to choose otherwise. If you are completing directives, then you must have some point in mind when you would not want heroics, where you would want a doctor to write a DNR order to protect you from the system. Adults in good health usually want and expect heroic resuscitation attempts if they're acutely ill or injured. That's why CPR was invented, and I'm glad we have it. But at some point down the line, maybe I'll have an unrecoverable injury and be in a vegetative state, or I'll be at the end stage of some incurable disease. Then I won't want heroics. But who knows when or if that will ever happen. That's what general advance directives are for. They limit nothing right now, but they can come into play for some unforeseen disease state in the future. Not a simple, curable, acute disease or injury, but one that I won't come back from. Then my physician at that time can use those directives to meet my wishes and write a DNR order. What if I have an advanced chronic disease state right now, or I'm simply getting old enough that my life expectancy is very short? Maybe I understand that my chances of a good outcome are low, even with heroic treatment. Here, my current disease state has influenced me and my physician to have a conversation about my goals of care and to complete a state-authorized portable order. If I'm admitted to the hospital and am unable to speak for myself, any physician can use this order to enact a DNR status for me. Theoretically, I could complete one of these even if I was completely healthy, yet was absolutely certain that I would never accept CPR under any circumstances, but that would be unusual. Typically, this is done as a result of advancing disease. Lastly, if a truly end-stage disease state already exists that has led to a decision for DNR, and if my physician recognizes that I may need to be transported outside the home or outside of the hospital setting, then he can complete an out-of-hospital DNR order for me. This will accompany me anytime I come into contact with the healthcare system, like ambulances or facilities, and will maintain me in a DNR status throughout. This order is only appropriate for end-stage disease states. In summary, we can consider the use of these different directives in terms of 3 locations of care and 3 states of health. If I'm healthy but have an unexpected illness or injury and an ambulance is called, everything is done to keep me alive to reach the hospital with hope of recovery. If I'm temporarily incapacitated, my proxy may be called upon to give consent for things like surgery or transfusion, but no one considers my living will documents at this point. I certainly hope I recover and return to normal life and that my advance directives are never needed. But if things don't go well to the point that I'm considered unrecoverable and either end stage or vegetative, then my advance directives will save me from being kept alive on machines. A DNR order would be written based on my advance directives, and my wishes will be met. Later in life, if I'm chronically ill and debilitated, I may still want conventional treatments like admission to the hospital for antibiotics, but I don't want CPR or heroic resuscitation. I complete a state-authorized portable order, checking the DNR box. When my pneumonia comes on fast, my family calls 911, but provides the ambulance crew with my pulsed order. This allows the crew to transport me to the hospital, start an IV, apply oxygen, and other conventional treatments while respecting my wish to be in a DNR status if I went into cardiac arrest. On arrival to the ER, the same pulsed order would allow a DNR to be written in the hospital. Could a living will do the same? Only if the patient were determined to be at end stage or vegetative, and the living will would have no role in the ambulance. The portable order provides a more immediate statement of my wishes when those wishes apply to me right now. Lastly, if I'm already at end stage and in a DNR status in the hospital, I may need to be transported by ambulance to home or to another facility. This puts me in contact with the healthcare system, but outside the hospital. In the back of the ambulance, the DNR order in the hospital chart means nothing. In the ambulance, I need an out-of-hospital DNR order to protect me during transport. If I had a pulsed order that indicates DNR, that would work too. But in the absence of that, the simplest way to continue the DNR status across all venues of care is the out-of-hospital DNR. Well, that was a lot of information in a short amount of time. I hope that this helped to clarify the different types of healthcare directives, when and where they apply, and why they are important to have. If you still have questions or would like help in completing directives, consultation with a palliative care specialist can save you a lot of time and worry. I'm Dr. Michael Cooney. Thank you for your time. Take care.